All right, guys, let's get started. Today we're talking about myocardial infarctions and their complications. The most important thing when you have someone with an MI, you really can't start narrowing down a question until you think about when it happened. So if they have some sort of complication within a day of their heart attack, you're thinking about shock and you're thinking about electrical issues. You can also have a stent thrombosis, although typically they'll make it very clear when that's the case. So the meat of kind of what we'll be doing is if you have someone within a week of their MI, so if you're kind of over here, that's when you're looking at either a papillary muscle rupture, an interventricular septum rupture, a free wall rupture, or maybe acute pericarditis. If it's been weeks to months since their heart attack, I can almost guarantee you the question will be about a left ventricle aneurysm. Of course, at any point, you can just be having another heart attack. So I want you to pause on this and just kind of look at it and commit it to memory. But essentially what we're talking about is you're either within a day of your heart attack, within 3 days of your heart attack, or within 2 weeks. And so at any point you can have an arrhythmia. But typically if you're around 3 days, what you need to differentiate is papillary muscle rupture and ventricular septal rupture. So that's kind of what we'll help you do today. When it comes to early post-MI, so if it hasn't even been 2 days yet, arrhythmias are the most common cause of death. And so two rhythms that you need to be familiar with is here, if you kind of look at, the very monomorphic peaks and waves here, this is called VTAC. And so the treatment for VTAC is going to be if they're either stable or unstable. Now, if you see kind of lines going every which way, there's no real morphology that you can identify, and there's also a little bit of a wandering baseline here. This is called VFib. And in the EMS world, it's considered bad form to even let this strip finish before you defibrillate them. And so defibrillation can also just be called you give them energy, you give them electricity, etc. So let's say within a day, someone has chest pain, altered mental status, and most importantly, they have hypotension and diminished pulses. This is just good old shock. If suddenly someone becomes pulseless, you might be thinking about VFib. If someone has chest pain and an EKG is showing ST elevations, but specifically where the stent was placed, this is called stent thrombosis. Really what we care about though is someone having complications within 3 to 5 days. This is where I've seen most of the UWorld questions come from. So the thing about papillary muscle rupture and interventricular septal rupture is they both cause a systolic murmur. And so if we kind of think about that here, we have a systolic, sorry, my handwriting is shit. If we think about a systolic murmur, if it's hollow systolic, you're thinking about an interventricular septal rupture. If it's a soft early systolic murmur, you're thinking about papillary muscle. I can almost guarantee you'll have a question differentiating these two. Now, of course, if you just get Beck's triad, this is when the free wall has just ruptured, and we'll talk about that in a second. So this is what I was trying to say earlier. If we just make it simple, if it's been over 3 days and they have a murmur, just look at the type of murmur and that will tell you your answer. If they have tamponade, which the main finding here is going to be a low blood pressure, you need to think about free wall rupture, and we'll have a picture in a bit talking about that. One other thing is, once you know the murmur, let's say they leave the murmur out, what are some other findings? And so with papillary muscle rupture, the main thing is very sudden onset pulmonary edema. When you have a septal rupture, not only will you have that harsh hollow systolic murmur, you have bilateral heart failure. And so this is when you'll see JVD and leg swelling. I think, you know, when we try to understand what exactly a papillary muscle rupture is, we need to kind of think about where the papillary muscles are. And so if you kind of remember, they're what kind of anchor the chordae into the muscle wall. And so let's just say we have a rupture here. You're going to then have a flail leaflet. And they might show that to you on echo on step 2 or step 3. It's, you know, it's definitely fair game. Now, a different but similar presentation, like we talked about, was the septal rupture. And so the main thing with septal rupture is kind of see the septum here, and then you see this jet stream coming across it. And so, you know, it is possible they might just give you an echo finding. And the murmur that it causes is a ventricular septal defect. Now, if you'll remember, smaller defects cause louder murmurs, and then if you ask someone to squat, then the murmur gets louder. Now, this one, it always kind of, sometimes it comes up. If it's been over a week, but typically up to a few months, if they give you any kind of chest pain that is positional, and especially if it gets worse when you're taking a deep breath, if they're being nice, they'll give you that, you know, scratchy pleuritic sound. This is pericarditis. Most specifically, it's an autoimmune pericarditis. And so I could see more of a level 1 thing where you might have to know that this is a, you know, type 4 type of response. You can also have pericarditis that's seen within a few days of MI, but this won't be diffuse. It'll be focal to the infarct zone. And the treatment for this is NSAIDs. So it's not steroids. That's the big idea. This one kind of tripped me up because it's one of those little numbers that you need to remember. Let's say someone's had an MI, right? So someone had an MI and then you do an echo. So if that echo shows that their EF is less than 30, they need a defibrillator placed. And the reason why is at any point they could just go into cardiogenic shock, and hopefully this will prevent that. So like we talked about with pericarditis, here we see kind of this, you know, cheese-like necrosis all over the heart, and so it's a diffuse autoimmune pericarditis. They're being nice, they'll give you the friction rub. You might have to look at the EKG, and it shows ST elevation in all leads. And so before you jump to the answer that says they're having a heart attack, look to see if the elevation is in all leads, because it might be pericarditis. And really the treatment is NSAIDs. Colchicine might still come up on COMLEX, but you can basically just use any NSAID. One thing you might have forgotten is the difference between type 3 versus type 1 collagen. And so if you kind of consider a heart attack like any other injury, you start getting some scar formation. So an early scar has type 3 collagen. Really, this seems low yield, but basically the big idea is that think of it as a very friable, immature kind of scar. It can rupture at any time and just cause sudden death. When you're months out from your heart attack, that scar has been replaced with type 1 collagen. This stuff, you know, is similar to what's used in bone. And so if this ruptures, it's going to cause heart failure, not sudden death. And a picture that makes more sense if you look at this, right? So this is a pseudoaneurysm. This is because this scar tissue that was here is very friable. And so it kind of caused an outpouching, but you still have the pericardium. And so, you know, you're basically bleeding out, but the blood isn't going everywhere. And so this is called a pseudoaneurysm because it doesn't involve all 3 walls. But when you have a mature scar, that's a true aneurysm, and it's just going to cause a dilated heart. You're not losing blood necessarily. So we'll do a practice question here. You can pause it, and then I'll go on to the next one. And so we have someone with 24 hours of chest pain. She's been sweating. And, you know, if we kind of blah, 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 skip all the stuff, she had a heart attack. On the third day of hospitalization, she developed shortness of breath. A soft early systolic murmur is heard at the apex. And so we kind of know that this is either going to be PMR or interventricular septal rupture. And when we see the word soft, it's when we start thinking about papillary muscle rupture. So I really highlighted the keys to identifying a PMR, and essentially it's that they have, you know, some sort of infarct, develop pulmonary edema, and develop that soft early systolic murmur. The key here is that there's no thrill to the murmur, and the murmur is not hollow systolic. And while she does have crackles, she has no signs of right-sided heart failure, such as edema in the legs or JVD. And we kind of already talked about this, so I'll skip it. And this is another important question, and so you can pause it and I'll go on. So really the key here, again, we can kind of skip all the presentation. Long story short, she had a heart attack and now has a loud hollow systolic murmur. And one thing they like to throw in is that there is a palpable thrill. And so again, the answer to this is going to be interventricular septal rupture. So a person dies 5 days after a heart attack. The pathology, when they do the autopsy, they take a slice of the heart and this is what they find. And so we have the interventricular septum and then kind of some necrosis and thinning of the tissue between the two ventricles. And so when we have that, would they have murmur A or murmur B? And so I'll let you think about that. And the answer is going to be a hollow systolic mitral regurg murmur. And again, this is interventricular septal rupture. So another question, a lady had cardiac cath. No stenting was performed. She suddenly, about a week later, develops chest discomfort. The lungs are clear. Cardiac monitor shows a junctional rhythm. And so essentially what's happened is that she has developed heart failure and we want to know why. And so when we think about something that doesn't have a new murmur and happened within a week of the heart attack, we're kind of left with free wall rupture. And so she has chest pain, no new murmur, eventually loses her pulse. So we're thinking about a rapid tamponade, and that's because the free wall ruptured. And again, just taking it back, that's this thing right here. That's what happened. She developed chest pain, no new murmur, and then suddenly, eventually became so hypotensive that she lost her pulse. And so this is, I think, a little bit of a harder question. I'll let you read it. And so the key here, when we think about, you know, an aneurysm forming, she began to basically just have a re-infarct at the same exact place the stent was placed. This is stent thrombosis. And the reason for stent thrombosis here is typically what happens when you leave the hospital after a stent. You're put on both Plavix and aspirin. right? And Plavix costs a bunch of money. And so they're telling you they were uninsured and basically asking why it happened. And so the reason is medication non-adherence. And so whenever you think about a medicine question and they try to add in an epidemiologic answer to it, just read the question and tell you what, and look at what they tell you. They were unemployed, and they're basically assuming you know that when you leave the hospital after a stent, you're put on some expensive medications. So this is just a different way to look at the same question. This time they were more straightforward. They just asked you to identify a coronary thrombosis. We'll just look at the keys here again. Hypotension, ST elevation in the same leads as where they had the heart attack. That's really the key. ST elevation in the same leads where you had the heart attack right after a stent was placed. Once you know it, it's pretty easy. This is a different question. What are you thinking about when you have heart failure months after a heart attack? Well, we kind of talked about it. Months after a heart attack, let's say you have some scar tissue. If it does rupture, it's pretty mature, so it's going to be contained within the heart, and you're going to have symptoms of heart failure. And so the answer here is a left ventricular aneurysm. The key here is that the defect presented months later and it caused shortness of breath progressing onto heart failure. This one really messed me up, and basically you can really ignore the whole question. All it's asking you is, in someone that's had a heart attack, what's their biggest risk factor for sudden death? And so it's something where you either know it or you don't, but you know, if someone had a heart attack, their biggest risk for death is sudden death from arrhythmia. And kind of integrating to what we talked about earlier, this person's EF is less than 30. That means they need a defibrillator. Just reiterating that point. In your heart attack questions, they might ask you, or they might tell you about an exam finding called hepatojugular reflux. And so basically that tells you two things. Whenever you have some sort of jugular venous distension, if you can make that jugular venous distension worse by pressing on the liver, then you have a heart issue. If pressing on the liver doesn't make the JVD worse, you have a liver issue. And the way to think about it is, when you have a liver issue, the pressure is here. And so when you press on it, this is so pressurized that it's not just going to shoot up fluid here. It's going to shoot this way, and your abdomen will swell up. So I would just be able to differentiate heart versus liver causes for right ventricular failure. This will help you out a lot. Let me just reiterate something here. So the hepatojugular reflux, it's basically when you have liver enlargement and abdominal enlargement, and you're trying to figure out why that is. And so they both have leg swelling and abdomen swelling. And the idea is, if you press on the liver and you can kind of send someone's JVD increasing, that indicates that the liver is fine. So if you studied some older resources, you might be familiar with MONA. MONA was the old 4-step treatment plan for someone with a heart attack. The thing is, though, we found out that when you give someone nitrates and morphine, you kind of impair their ability to tell you whether they're having chest pain again. And so the new thing, there's a really long mnemonic, but I kind of summed it down to ABS pretty hot, ABSPH. I would commit this to memory. And they're really kind of what they'll do is they'll describe someone who is like given a bunch of meds, right? Like, let's say they already gave them for them. You might just have to identify what's left. Or they might add in something like, they also gave the patient morphine and they ask you if they should stay on that. One thing you need to know is if someone's presenting with chest pain and they give you the results of a coronary catheterization, you need to know if they need a stent or a cabbage. And so really the main one is if they have more than 70% of LAD stenosis, they need a cabbage. The other kind of trickier thing would be if they have already gotten a stent, but they're still having chest pain. But really, this one right here is what you need to know. And so one thing that kind of confused me is when you have a cabbage, it's kind of it's common to have AFib afterwards. And so this can happen in up to half of the people that get one. The confusing thing is that it's self-resolving. So you don't need to cardiovert them. You don't need to give them antiarrhythmics. All you do is give them beta blockers. This one kind of got to me. It kind of showed me that there's always a different diagnosis you forgot about. And so I'll let you guys read this one and kind of see what you think. And so the answer to this one is you need to basically crack open the chest again, which is super unfortunate, but it's kind of, you can't avoid it. And so what really got me is I thought because they had AFib that we needed to do some sort of cardioversion. However, kind of consider that they have a fever. Do you typically have a fever in AFib? No, you don't. They had mediastinal widening. Is that caused by AFib? No, it's not. Essentially what's happening here is you have a deep chest infection, likely from not maintaining sterile technique. And so their diagnosis here is mediastinitis, which basically you give them every antibiotic available at the hospital and you do surgery again. And so kind of summarizing what we learned today, you need to have this timeline memorized. You need to identify VTAC and determine if they're stable or unstable. You need to know that with VFib, you shock them immediately. Be able to distinguish between papillary muscle and interventricular septal rupture. Be aware of Dressler syndrome and that you treat it with NSAIDs. Be aware that once you leave the hospital, you're typically on dual antiplatelet therapy. Be aware that people with sudden cardiac death maybe could have been avoided if they had an EF less than 30, if you had gotten them a pacemaker. All right, guys, that's about it for today. Thank you.